So today, chapter 10 on the muscular system, I know I mentioned it's a pretty short chapter. We're really talking about muscles, so just the muscles of the body. We will walk through some of the muscles that you're going to identify, their names. In fact, I'll spend a little bit of time here at the beginning talking about how we name our skeletal muscles. A lot of our muscles are named for the bone markings. So if you knew, and if you did well on the lab midterm and you know those bone markings, I think you'll do fine in terms of skeletal muscles. They're named for bones. They're named for a lot of different ways, but we'll walk through that. We'll also talk about how the fascicles in muscles are arranged. Remember, fascicles are like the bundles of cells. So it's like a big bundle of cells in there. And that'll give you like the striations in the muscle, sort of. So we'll talk about that. And then we'll walk through something called the origin, action, and insertion list. You have this list in the lab PDF that will be included in the lab exam. And so I'm going to walk you through this list, and we'll talk about a couple of specific muscles, and then we'll talk about a couple of disorders. Okay. So when we talk about muscles of the body, remember, your muscles either work together to perform an action or they work in opposition to each other. So a good example would be like when you flex your arm, right? When you are flexing at your elbow there and you're flexing your arm, you have a couple of muscles up in here, like your bicep muscle and your brachialis muscle, which is right underneath. Those muscles are performing the action. So they're working together to flex, right? But muscles also work in opposition to each other. So to undo this action, it's a different muscle. To extend back out, it's your tricep muscle back here, okay? So they're either working together to perform an action or they're opposing the action. So when we say, like, if you work out, you lift weights, we tell people work opposing muscle groups. That's what we're talking about. If you're going to work muscles on one side of the joint, like your bicep, make sure that you also work out your tricep on the other side of the joint, okay? Muscles only pull. They never push. So remember, if we think back to muscle physiology, remember that sarcomere can get shorter, right? So a muscle can pull and get shorter, but a muscle cannot push. So that's where this comes into play, this whole opposition to each other. Again, if we think about flexing at the elbow, right? If we think about flexing the arm, your bicep does that because the bicep is pulling, right? Your bicep is connecting down here at the radius and the ulna, and it's pulling it, okay? So muscles only pull, they never push. So your bicep can't push it back out. That's where your tricep comes in. Your tricep's going to pull it the other direction, and it's going to extend back out. Okay, so muscles only pull, they never push. And as a muscle gets shorter, the insertion gets closer to the origin. So remember those terms. The insertion is the one that moves, right? This is the movable bone. The origin is the one that does not move. Okay, so let's think of like the sternocleidomastoid muscle. That's this muscle right here. It runs from the sternum and the clavicle up to the mastoid process behind your ear. And so this one is involved in neck rotation, right? So head rotation. So when you turn your head to the side, okay, what's moving is not down here. The sternum and the clavicle aren't moving. It's this mastoid process, right? It's pulling on that mastoid process. And so we say that that's the insertion up there. That's what's moving. Okay, the origin is down here, the sternum and the clavicle. And you'll also notice that the insertion, when that muscle contracts, the insertion, the mastoid process, is getting closer to that origin, the sternum and the clavicle. Okay? Whatever one muscle does, another muscle or muscle group will undo. Okay, so again, you can think back to that whole flexing and extending of the arm at the elbow, right? Your bicep and your brachialis muscle, these will flex. The tricep will extend back out. So what one muscle does, another muscle has to undo. Okay, Boy, it's hard to zoom on here because then I have to like hold my body parts up. Y'all can't see everything. So for all the muscles that we have in the body that y'all are going to look at in your lab this week, we classify them into 4 functional groups. Okay, so one, we can classify them as a prime mover. This means they are providing the major force for that movement. Okay, so again, let's go back to flexing at the elbow. Sorry, I keep using that example, but that's the only one y'all can see on me. So flexing at the elbow, right? The prime mover is going to be that bicep muscle, okay? The antagonist is going to oppose or reverse a movement. So in this case, when we're looking at flexing of the arm, the prime mover is the bicep. The antagonist, what undoes it, is the tricep, right? A synergist is just a muscle or group of muscles that's going to add extra force to a movement. So again, if we're looking at flexing at the elbow, the synergist might be the brachialis. It sits just under the bicep brachii. Okay, that's going to add extra force. It's going to help it out when we flex. So you kind of have 2 muscles helping to perform that function. So we would say that the brachialis is a synergist. And then the last thing is we have fixators. And fixators are muscles that can help to immobilize a bone or prevent sort of a joint from moving. And a good example of a fixator would be like, I'm going to use this one, we'll say, we call these muscles in here, they kind of run up your forearm and out to your fingers. We call them your hand flexors. Okay, and these muscles, you can see they're running up the wrist, so they help flex at the wrist, but they also run all the way out to your fingers, so they also flex your fingers, so they provide this kind of motion, right? But you can flex the wrist without flexing the fingers, right? And so those would be some fixator muscles that are up in here that are preventing those joints from also flexing. You can flex the fingers without flexing the wrist. So again, you've got some fixators that are helping to immobilize that area, okay? So those are our 4 different functional groups. Now again, the muscle that we're using for each of these might change depending on the action we're looking at. So let's go back and look at the examples that I gave you for prime movers and antagonists and synergists, right? The example that I gave you was flexing, okay? If you flex at the arm, prime mover is the bicep, antagonist is the tricep. Now think about this. Let's say that the action I'm giving you is extending the forearm at the elbow. What's the prime mover? It's not the bicep anymore, right? If I'm saying, hey, the action is extending at the elbow, then you would say the prime mover is the tricep. That's what's doing the action. And the antagonist would now become the bicep brachii. So these will vary based on the action we're looking at, okay? Hopefully that makes sense. I'm going to walk you through how we name our muscles, and I think this will be super helpful as you all do your lab PDF for this week. We name our muscles for lots of different reasons. So I have 7 different reasons listed here that we're going to walk through. The first one is we can name our muscles based on their location. So maybe the bone or even the body region that they're associated with. So a good example might be like the muscle that's right here. This is a muscle that's in your forehead. It actually helps you raise your eyebrows, okay? And so this muscle right here is called the frontalis muscle. This one gets its name because it's sitting on top of the frontal bone, okay? Another good example might be on the sides over here. Ooh, my hair looks bad today. On the side over here is our temporalis muscle. This one gets its name because it sits on top of the temporal bone. You also have one in the very back called the occipitalis muscle. Gets its name because it sits on the occipital bone. So these are named based on the bone that they sit on. Sometimes it's also based on body region. We can name our muscles based on their shape. So a great example of that is you have a muscle in your shoulder that's sort of a triangular shaped muscle called your deltoid muscle. This one helps you lift your arm up to the side. Remember, we call that abduction. That's your deltoid, and it gets its name because of the term delta. If y'all are familiar with math, you know, when you draw a delta or change of in math, it's a triangle. So the deltoid muscle is a triangular shaped muscle. You also have in your back a trapezius muscle, which is shaped kind of like this. It's shaped kind of like a trapezoid. So we can name them for their shape. We can also name them for their size. So we have muscles like maximus, medius, and minimus. Your gluteus muscles, they're named based on their size. So you have one that's really large, then underneath it you have a medium, and then you have a small, right? Maximum, medius, minimus. We can also name them or put a name in called longus or brevis. That tells you if the muscles are really a long muscle or a really short muscle. We can also name our muscles based on the direction of the fibers. Remember that term fiber means cell. So the direction that the cells run. If your muscle cells are running up and down and they're straight, we call that rectus. So like your rectus abdominis, these are the muscles right in the middle of your abdomen that give you that six-pack appearance. Okay, I don't have that clearly, but if you did, that's your rectus abdominis. I have a rectus abdominis, you just can't see it. The transverse muscles, transverse means it's running right and left. So you also have a transverse abdominis where the cells are running this way. Oblique means diagonal. And so you also have an internal and an external oblique abdominal muscles, and they're running at an angle. Okay. So when we talk about direction of fibers, we see this a lot, especially in the abdominal muscles. We actually have 4 abdominal muscles that sit on top of each other. And that's really important because your abdominal muscles, if you remember that whole region down there, you don't have any bones. So the forms of protection that you have is you have a greater omentum, which is fat. That's going to help to absorb some shock and cushion those organs. But then you have 4 layers of muscle. And those 4 layers of muscle are also nice and protective. Okay. So we can name our muscles based on the direction that the cells are running. We can also name our muscles based on the number of origins. Remember that term origin, it means this is the part of the muscle where it connects that does not move. So your bicep, bi means 2, and your tricep, tri means 3. They have 2 and 3 origins respectively. We can also name our muscles based on the location of their attachments. So basically their origin and their insertion. Great example of that is the muscle I gave you earlier, the sternocleidomastoid muscle. It is named for the origin, sternum clavicle, sternocleido, and the insertion, mastoid. Okay. And then last is the action. A lot of times, if you see the name flexor or extensor in the name of a muscle, you know what it's doing. It's either flexing or it's extending back out at that joint. Now, a lot of times we use, of these 7 criteria I just walked you through, a lot of muscle names have more than one of those criteria in them. And so here's a great example that I added in. This muscle right here, this is not one that you have to learn. It's not one that's on your lab PDF. It's called the extensor carpi radialis longus. This has a lot of these criteria in it. But let's just walk through it, and you're going to figure out, just based on the name, where it's located, where you can find it, right? So extensor carpi radialis longus. So extensor means that it's going to extend at the joint. Okay, so all right, keep that in your back pocket and think about that. Carpi, think about what that means. Carpi, carpals, wrist. Okay, so now we know, all right, we're looking at a muscle that is near the wrist, and it's going to extend the wrist. Okay, so remember, flexing the wrist looks like this, extending the wrist looks like this. If we know it's extending and we know muscles only pull, they never push, we know it's going to be on this side. right? It can't be on this side because it can't push it out. It's got to be on this side so that it can pull it and extend it. Okay, so now we know we're looking at a muscle on this side, the posterior side of your forearm. Radialis, okay? Now we know it's running by the radius. Okay, now remember the radius is always on the side closest to your thumb. So now we know we're looking for a muscle that's over in this area, running over by your thumb. And we also know we are looking for a muscle that is nice and long. So just based on the name, we should be able to get a really good location on where that muscle is. So use this as you're doing your lab this week. Pay attention to the names of these muscles. It'll really help you. Hello. Oops. Sorry, my watch is talking to me. I also want to walk you through a little bit on the arrangement of fascicles in our muscles. So remember, muscle fascicles, these are bundles of cells. So in terms of muscle fascicles, and how they're arranged. Depending on how they're arranged, it can really influence the force of a muscle. So basically how strong of a contraction you can get. This is obviously going to be dependent on the number of fascicles. Because the more fascicles you have, remember these are bundles of cells. The more fascicles you have, the more cells you have. So the stronger and the more force you can get out of that muscle. That should make sense. And then also fascicle arrangement will also determine muscle speed. The longer the muscle is, the more parallel those fascicles are with each other, the more it can shorten up. Okay, so a good example is you have a muscle that's in the front of your thigh, and it sort of runs from the outside, like by your hip, all the way to the inside of your knee. So it's a really long muscle. It almost looks like a sash running across your muscle, running across your thigh. It's called the sartorius muscle. Because it's so long, it is really going to help with the speed of that muscle, helping that muscle contract faster. And it can shorten up a lot. So fascicle arrangement, how those fascicles are arranged will determine not only the function, which we just kind of looked at right here, but also the shape of a muscle. So let's walk through the shape of our muscles. So if you have a parallel fascicle arrangement where all the fascicles are running right next to each other, nice and parallel, then the muscle ends up being very long, very skinny. So the example that I just gave you a minute ago, the sartorius, this is a muscle that's kind of like a sash. Let me show you where it is on the whole body. It is this one right here. Okay, it's running from like your outer hip to the inner side of your knee. It's really long and it contributes a lot to the force of that muscle. Really helps it contract quickly. A fusiform arrangement. This is going to give you more of a spindle-shaped muscle where it's kind of more narrow on the ends, you can see here, and it's a little fatter in the middle. A great example of that is the bicep brachii. Okay, so let's look at a fusiform arrangement and that bicep brachii. So here's your bicep brachii, right? This helps to flex at the elbow. You can see it's sort of a spindle-shaped muscle, fusiform. Pennate. So pennate is when the fascicles are shorter and they are connected to a central tendon. When I hear the word pennate, I think pennant, like when you're at a football game or a sporting event and there's a pennant and you're flying that, that's a flag, little flag. And so I always think flag or feather. So when I see that word pennate, I think feather, flag. These have sort of this feather. They look like a feather to me, right? If we look here, this is what's called a unipennate muscle. Uni means one. Okay, so here's this one tendon in gray. Okay, a lot of times, we'll see this later in the chapter, a lot of times gray is, they're trying to depict a tendon and the red is the muscle. So you can see that gray tendon, there's one, and you can see all these muscle fibers and fascicles connecting, and they're short, connecting to that tendon. That's unipennate, looks like a little feather, okay? Bipennate Okay, so we have this one tendon and it's running right down the middle. But in this case, bi means two. And what we're seeing is we've got muscle fascicles connecting off of both sides. So off of two sides of that tendon. And then multipennate, multi means many. We have many of these little tendons in here and the muscles coming off of there, those muscle fascicles. And so those are obviously also going to determine the shape of a muscle. Now something that's unipennate very much looks like a feather. And a great example of this is the extensor digitorum longus. So the extensor digitorum longus is right, they're trying to show it to you over here, but it's down here, okay? Extensor means it's extending back out. Digitorum is your digits, so it'd be like your fingers or your toes, and then longus, it's a long muscle. Bipennate would be like the rectus femoris. So the rectus femoris is this muscle right here in the leg. It's a really big leg muscle. And that one tells you it's in the femur. It's near the femur because it's femoris. Okay. And then your deltoid muscle is a good example of multipennate. So it gives it that triangular shape. And remember, your deltoid muscle is this sort of triangular shaped muscle up in the shoulder. Now we also have convergent fascicles. That means that all these muscle fascicles converge to this one point over here. So a great example of convergent fascicle arrangement is the pectoralis major. Okay, so you can see that here. Some people call these their pecs, right? Pectoralis major. Well, also your pectoralis minor is convergent. The serratus anterior, another muscle that you'll look at in the lab this week, it's also convergent. Okay, it's where they're converging to this one point. And then lastly, we have circular fascicle arrangements, and it's where the fascicles literally are in a circle. And so when those muscle cells contract, the opening gets smaller. These are called sphincter muscles. We often find these in openings to our body. So the mouth, we call this the orbicularis oris. This is your kissing muscle, right? It allows that opening to get very small. That's a circular arrangement. The orbicularis oculi, which goes around the eye, right? That is also a circular arrangement. It allows your winking muscle, right? Allows you to close that. But other sphincter muscles, you've got sphincter muscles internally as well. You have some sphincter muscles at the opening into the stomach so that when you eat food and food goes into your stomach, it closes. So it keeps food from regurgitating up. Sometimes if you eat too much or you eat spicy food, a lot of times that sphincter muscle can't close all the way. And if that happens and it stays open, that food and gastric juice can move back up the esophagus. You get heartburn, right? You have a sphincter muscle at the end of the stomach, allowing food to slowly move into your small intestine for absorption of nutrients. You've got sphincter muscles in the anal canal, helping you to control defecation. You've got them also in the urinary tract, helping you control urination. So sphincter muscles are just round and they just allow openings and closings, okay? So they're showing you in this picture the orbicularis oris, the one around the mouth, your kissing muscle. All right. So I also want to walk you through, and you are going to see this in the lab. I want to walk you through what's called the origin, action, and insertion. This is the origin, we know, is the immovable bone, right? Does not move. The insertion is the movable bone, so it does move. And the action is what the muscle is doing, what action it's performing, okay? Be aware of the name of the muscle, because a lot of times in the name of the muscle, it might tell you the action, right? If the action is to extend, you might see the word extensor in the name of the muscle. And so there is an origin, action, insertion list. There are 32 muscles that are in the lab PDF. Okay, so these are in the lab PDF. And What I give, I don't know why I wrote PAF, PDF. What I give you in the lab is I give you a list of muscles. I give you, so the name, I give you the origin, I give you the insertion of those muscles, and then I give you the action of the muscle. You need to know those. I will ask you, there will be on your lab quiz, there will be some questions on origin, action, insertion. And on the lab final, sorry, there will be questions on origin, action, and insertion. So there's just a table that's in your lab that you need to know. Now, in terms of learning this, the best way to learn it is just to act it out. So as you're looking at the muscle, a lot of these are muscles you had to identify in the lab PDF, so you should know where they are located. But kind of, you know, if, for example, it is the bicep muscle, right? And it says, okay, so the origin of the bicep is up the coracoid process. That's the origin, and the insertion is down on the radius and the ulna. And the action is to flex the arm at the elbow. You're acting it out. So you're going to point at the origin, point at the insertion, and then act out, okay? That action. That is the best way to learn these. How I will ask you questions on the lab quiz and on the lab final is I will give you the origin, the action, and the insertion. So I'll give you all of that. You then have to type in the name of the muscle, okay? This is going to be really hard if you don't know your bone markings. So if you never learned your bone markings, if you didn't do well on that part of the lab exam, this will be difficult because a lot of these origins and insertions are bone markings. They're parts of your bones. So act them out. I give you all that information. You type in the name of the muscle, okay? All right, so I'm going to walk you through a couple of the muscles in the body. We'll kind of start at the head and work down towards the toes. I'm going to start with muscles that are in the face. You have 11 muscles that are involved in facial expression. This is anything from lifting the eyebrows to smiling to flaring your nostrils, frowning, kissing. All of those are facial expressions. Remember, your skeletal muscles are all controlled by your brain, by the nervous system. So remember, when we draw out muscle fizz, right, we always draw out that neuron coming into the skeletal muscle. Okay, so keep that in mind. All of the muscles that are of your inner face, they are all controlled by cranial nerve number 7. Okay, so they're all controlled by neurons and by nerves. So cranial nerve number 7, you actually have nerves that come off your brain, your 12 cranial nerves. Number 7 is called the facial nerve. And this is a nerve that's going to come off the brain and it's going to come out and it's going to hit all these different muscles that are in the face. It's going to provide you with facial expression. Okay. Now, one thing, and the reason I'm pointing out some of these muscles of the face is because one thing that's very different about them, if we think about origin, insertion, and action, normally the origin, I told you, is the immovable bone. The insertion is the movable bone. When we're talking about muscles of the face, they do not insert into bone. Instead, these are muscles that are going to insert into the skin and other muscles. And so when that muscle contracts, like think about your frontalis muscle, for example. This muscle, the origin is going to be on the frontal bone, but the insertion is going to be the skin and the muscles around your eyebrows. So when this muscle contracts, you are lifting your eyebrows, right? So it's not inserting on another bone, it's actually inserting in the skin and the muscles, okay? So that is one huge difference of the muscles of your face is in terms of their insertion. They're not inserting into a bone typically. These are just some examples. Now this is a picture from your book. These are some of the muscles that you need to know from the lab PDF. Like for example, the temporalis muscle over here, okay? And I just did the frontalis muscle with you, which my Zoom is in the way. Let me move that out of the way here. Okay. This one's called the frontal belly. They call it the frontal belly. It's the frontalis muscle, okay? Some other muscles of the face would be things like the orbicularis oculi, goes around the eyes. Another muscle might be like the buccinator. The buccinator is this little muscle in here. We call this the sucking muscle. So if you're sucking out of a straw, it's the buccinator muscle that helps with that. Let's see, we also have the orbicularis oris, which goes around the mouth, okay? And we even have this muscle down in here called the platysma muscle. So you can see this one, it's actually this muscle, and it's gonna connect to all these muscles that are in here, kind of in the lower part of your jaw. And when this muscle contracts, it pulls the sides of your mouth down. So that's your frowning muscle. Okay. We also have this muscle, the masseter muscle. This is one that's here. When it contracts, it's going to help to pull your jaw up. So it's your chewing muscle. And the sternocleidomastoid. I've talked about that one. That one turns your head side to side. So those are just some examples of some of the muscles that y'all are going to be looking at in that lab PDF, some of those facial muscles. Now, these are muscles you're not going to look at in the lab PDF. I don't have any images of these, but it's pretty interesting, so I like to talk about it. It is in chapter 10. These are the muscles that are of your tongue. So your tongue itself is a muscle, right? People eat tongue. Does anybody eat tongue? Like, anybody eat it? Somebody told me once there's a place in Northport that has beef tongue tacos that are super good. I don't know that I could eat tongue. It's just not my jam. But tongue is a muscle itself. So we have intrinsic tongue muscles, and these just help to change the shape of your tongue. Like they can make it pointy or make it flat. The ones I'm going to touch on are the extrinsic tongue muscles. These are the ones that are outside the tongue. They help to move the tongue around the mouth. So there's actually 3 extrinsic tongue muscles that I'm going to walk you through. These are all named for their origin and insertion. Okay, so the genioglossus, the hyoglossus, and the styloglossus. Notice they all have the ending glossus. That's because they all insert on the tongue, and glossus means tongue. Okay, so the genioglossus, geni is chin. Okay, so the origin of the genioglossus is the chin. It's sort of the back of your chin, and it's going to insert on the tongue and the hyoid bone. And its job when it pulls, let me show you a picture of it. So it's this one right here. Okay, it's that muscle. You can see it's inserting on the chin and it's running back to the tongue. When this one contracts and pulls and squeezes, it's actually going to push the tongue forward. So it helps you stick your tongue out. Okay, so you know, if a little child turns around and sticks their tongue out at you, they're using their genioglossus. This is really weird, but I want you to do this. It's not exactly true, but it's how I remember it. If you stick your tongue out really hard, like really hard, you kind of start to feel it. Like you can feel that muscle working. Like if you leave your tongue out, you can kind of feel that muscle working. You kind of feel it start to tingle behind your chin. Okay, so genioglossus. The hyoglossus, the origin is the hyoid bone. And so let's look at a picture here. Here's the hyoid bone. So the hyoglossus runs from the hyoid bone up to the tongue. And the job of this one when it contracts is it's going to kind of depress the tongue. It's going to pull it down. That one's really helpful when you're swallowing. And then the styloglossus, the origin is the styloid process. Again, the insertion's the tongue glossus. And this one, you can see it runs from, here's that styloid process. So it's going to run from the styloid process to the tongue. And this one is going to pull the tongue back in the mouth. It's going to retract that tongue. So remember, what one muscle does, another muscle or group of muscles will undo. So the genioglossus sticks your tongue out. The styloglossus will pull it back in. Okay, it'll retract that tongue. Okay, so those are some of our tongue muscles, extrinsic tongue muscles. Another muscle that I want to walk you through, again, not on the lab PDF. No, it is on the lab. It is not on the lab PDF, but it is in the origin action insertion list. This is the diaphragm. So the diaphragm is a muscle. It is this really thin muscle that separates your thoracic cavity from the abdominal pelvic cavity. And it is incredibly important in respiration. So it really helps with breathing. So in a relaxed state, your diaphragm is domed. It's actually bubbled up, kind of shaped like this. So it's kind of sitting up. And so what that means is in a relaxed state, your diaphragm is bubbled up, so the thoracic cavity will be smaller. The abdominal pelvic cavity at that point is bigger. Okay, so the diaphragm does this kind of movement. Bubbles up, flattens down. Bubbles up, flattens down. Obviously, that's going to play a role in breathing because it's going to change the space you have in the thoracic cavity, right? So when it's relaxed and bubbled up, you are going to exhale. When it contracts and flattens, you inhale. So we say that inhalation is an active process. You are contracting your diaphragm. And then exhale is passive. It's relaxing back out. Inhale, it contracts. Exhale, it relaxes and bubbles back up. Okay. So obviously this plays a huge role in breathing, but it also is playing a role in changing the space you have in the thoracic and the abdominal cavities. This is also going to lead to pressure changes, okay, especially in the abdominal pelvic cavity. So I want you to think about it. When you are blowing out, the diaphragm bubbles up, space in the thoracic cavity gets smaller. That makes sense because your lungs are deflating, right? But now the space in the abdominal cavity is bigger. When you breathe in, the lungs fill up, so the thoracic cavity gets bigger as that diaphragm contracts down, but the abdominal cavity is getting smaller. So the pressure in the abdominal cavity is going up. So when you take a big breath in, that diaphragm's pushing down, the abdominal cavity is getting smaller. Pressure down in there is now rising. This is actually going to play a big role in terms of the circulatory system and the lymphatic system. It's going to help to move your blood, keep your blood moving, keep your lymphatic fluid moving. It's also really helpful in pushing things out of your body, like feces, urine, and babies. Okay, so, when a woman is in labor, a lot of times, there's heavy breathing. A lot of times when her doctor is telling her to push, they usually will say, take a deep breath and hold it. Now push. Think about why they're doing that. You take a deep breath in and that diaphragm's pushing down. Now you have more pressure in the abdominal cavity and it's going to help you get that baby out. It is the same thing when you're defecating. Take a big breath in and push. It's going to help with passing that feces as well. I have a funny story about my son. This is probably gross and I shouldn't tell you, but he likes to get very comfortable when he goes to the bathroom. And when he was in kindergarten, I got a note from his teacher about how good he was and what a good friend and a good helper he was being. And so I picked him up from school and we went to Target, and I told him, normally we do not buy stuff unless it is Christmas or birthday or he's done something amazing. That's it. And so we went to Target and he's asked me, how many things do you have to buy? He always asks how many things. My answer is usually less than 100. We're at Target. Less than 100. And he asked, how many things do you have to buy? I said, well, less than 100. Do you want to walk through the toy aisle and just kind of look? And he knows when I say look, you just look. We don't buy. We go through the toy aisle and he sees something and he's playing with it and he really likes it. And I said, do you want to get that? And he said, do you mean now? I said, yeah. And he said, you mean I can take it home? I said, yeah. He said, yeah, I want to get that. But first I have to poop. Okay. So, when a 6-year-old tells you they got to poop, you got to run. So we run to the front of the store and he goes into the bathroom and I go in with him. We're in the ladies' room. And he gets in and he won't let me in. He goes into the stall and locks it. He needs his privacy. So I'm standing there and he is in there making all kinds of noises, like grunting. Ugh. And I'm getting super embarrassed because this is pre-COVID, so people are walking in and out of the bathroom. And it's like 10 minutes goes by. And I'm like, buddy, are you okay? And he's still grunting, making all kinds of noises. It is very obvious he is taking deep breaths in, holding and squeezing and pushing. I said, are you okay? He said, yeah. And I then decide I'm going to peek under the stall. That child has taken off his shoes, his socks, his t-shirt, his pants, and his underwear. He is butt naked on a public restroom at Target. I was so grossed out. Anyway, it's way more than you needed, but that is my story about pushing out feces. If you've ever been around a child going to the bathroom, you know how important that diaphragm is at pushing out. Okay. So here's an image of the diaphragm. This one is a weird view of it. You're kind of looking down. So it'd be like if we chopped off somebody's upper half. Take off the thoracic cavity and look down on the diaphragm. That's what both of these images are. You can see back here, these are the body of the vertebrae. Okay, these are the ribs, right? That's like the costal cartilage, ribs and sternum. So we're kind of looking down. One thing that's very different about the diaphragm is the origin is all over here. So it's everything that I just did in red. So it's all of like the costal cartilage and the body of the vertebrae. The insertion is this white thing right here. We call that the central tendon. So that's the insertion. That is a big difference that we find with the diaphragm compared to most muscles. Okay. Now the image at the bottom, this is just of a cadaver. Same thing, it's sort of like we lopped off the entire thoracic cavity. And so you can see that diaphragm obviously is not contracted, right? So it is bubbled up, right? It's not contracting, it's bubbled up, it's relaxed. You can see we're looking at it, it's very dome shaped right in here. Okay, here's the body of the vertebrae. This would be like the rib cage all the way around. And then you can see this dome shaped diaphragm in here. This right here is actually part of the pericardium. So you can see the heart sits right on top of that diaphragm. And then these back in here, these are our major vessels, right? So like the aorta and the superior vena cava. All right, so we're gonna move down into the abdominal cavity. So the abdominal wall. I mentioned this already. So the abdominal wall has 4 muscles. They all sit on top of each other. And the fascicles that are in those muscles are all running at different directions. So we have rectus running up and down, transverse running right and left, and obliques running at diagonals. So this is going to give the abdominal wall extra strength. So remember, I told you that we have no bones there. Instead, we have fat and we have 4 layers of muscle. Okay. Now, these muscles in the abdominal wall, we call these your core muscles, right? These are your abdominal muscles. They help with flexing, okay, right? So sitting up, flexing. They help with lateral rotation, side to side. Also, when these muscles contract, they push in. So they're also going to be used to help to promote things like urination and defecation and childbirth and vomiting and coughing and screaming and all of those things. We were not home this weekend. My son plays hockey, and he had a hockey tournament in Charleston this weekend. And you know, as a parent, when your child plays sports, I don't know if y'all have children yet, you as a parent have to sign like a waiver that says, like, basically, I'm going to behave and I'm not going to be bad and I'm not going to yell at the ref and I'm not going to yell at the coaches and I'm going to be a good example. And so I seriously had to I had to pray while I was in the stands, like, please, 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 God, do not let me say anything mean or nasty and let me be a good example to these children, because the ref was awful. I think that ref forgot where his whistle was and he did not blow the whistle one time. Somebody was going to get hurt. Woo, I was good, but a lot of these other mamas and grandmamas, woo, they were not good. And you know, when you're screaming through a mask, like, you have to yell louder. And so I can imagine that their abdominal muscles were pretty sore the next day because there's lots of screaming going on. So all of those things, you know, if someone's ever made you laugh really hard, a lot of times you'll be like, stop, stop, my stomach hurts. You have to stop making me laugh. So here are your abdominal muscles. You can see those 4 layers, right? So we have on the very outside, we have this one right here, and they've tried to cut it so that you can see underneath. So on the very outside is the external oblique. So I'm going to write a number 1 next to that one because that's on the very, very outside. And just underneath that, you have, I'm going to put 2 next to both of these. You have the rectus abdominis running up and down. That's our 6-pack that we think of. It's right in the middle. You can see it on both sides. Okay, so these are on both sides. They're paired. And then we also have, so sorry, this is also over here, that external oblique. And so underneath that external oblique, you can only see it over here on this right side. So we have our rectus abdominis, you can see here, and now we can see the internal oblique. And notice the difference is that those fascicles are running at a different angle, right? The external oblique, they're running this way. Internal oblique, they're running that way. Okay, so those would both be 2, internal oblique and rectus abdominis. Those are both kind of that second layer in there. And then the deepest layer, which runs all the way across, is the transverse abdominis. And you can see it's running right and left. Okay. Now, in reality, it's 4 layers of muscle. I just put a number 2 next to both the internal and the rectus abdominis because they're kind of at the same point in there. I'm going to also walk you through our shoulder muscles. So we actually call the shoulder muscles, and you may want to star this because a lot of students will get this confused on the exam. We call them our sits muscles. Now, a lot of students get this confused because they see the word sits, or that acronym right there, and they immediately think their bottom. Sits, in this case, each of these letters represents the first letter of the muscle. So your shoulder muscles are the sits muscles because S, supraspinatus, I, infraspinatus, T, teres minor, and S, subscapularis. Now, most of the muscles that I just listed off, I know you don't know where these are, but you should know the bone markings. Most of these were named for bone markings. So the supraspinatus, this is named because it's the muscle that sits in that supraspinous fossa. The infraspinatus sits in the infraspinous fossa, again, it's up in the shoulder. Teres minor and the subscapularis is named because it sits in the subscapular fossa. Okay. Those are our rotator cuff muscles. And the main job of our sits muscles, our rotator cuff muscles, is just to reinforce that shoulder joint. Remember, your shoulder does not have a lot of bony connections. It only connects at one point right here to the axial skeleton. And so it is held in place by a lot of muscles. So this is a view of the shoulder. So this view over here on the left, this is from the back, looking at someone from the back. Supraspinatus, infraspinatus, right here's the spine of the scapula. Okay, here is the teres minor. And then if we flip it and we look at it from the front, and that is the image over here on the right, we can see the subscapularis. Okay, so those are our rotator cuff muscles, our sits muscles. Now, the last thing I'm going to walk you through this morning are just a couple of disorders. So notice I did not walk you through every muscle in the body. You're doing that on your own. You're looking at your PDF. You're making sure you can find all of these. We will go over the lab PDF next Monday, like we normally do. And I'll give you some ways to remember some of those muscles. I know some of them are hard to remember, but I will give you some ways to remember those next week. But your job for lab this week is to just try to identify all of those, okay? Some of our muscle disorders that I have listed here are things like carpal tunnel, hernia, shin splints, and a Charlie horse. Now, some of you, well, I know all of you have had shin splints before, so we're going to talk about what that is. I'm going to start with carpal tunnel. So carpal tunnel is where the tendons that are running, so we call these your flexor muscles, remember, and they flex the wrist and the fingers. All of the flexor muscles are actually down here in your forearm, and as they move up through the wrist, they turn into tendons. I lost my pen. You can see that right here. So you can see all these tendons in here, okay? And all of those tendons, you can probably feel them also. If you kind of feel in your wrist, you can feel all those tendons in there. It feels like little cords. As they move up into your palm, they actually pass underneath something called the flexor retinaculum. Okay, and so you can see that it's right in here. And this is basically a tendon that is essentially connecting a big muscle over here and this big one that's meaty part of your thumb right here and over here. So it is creating like a little tunnel, okay? And so all of those tendons are running under the flexor retinaculum. You can see them popping out here. And so that's why we literally call that the carpal tunnel. It's a tunnel that's in the wrist that everything's running through, okay? And so what can happen if you are overusing your wrists? You know, maybe you sit on a computer and you use your mouse all day long. Depending on what you do, a lot of times all of those tendons in there, especially if you're doing this movement a lot, those tendons can swell through overuse. And as they swell, because they're running under that carpal tunnel, under the flexor retinaculum, they have nowhere to go. You also have a nerve that runs through there. The nerve is called the median nerve. Let me see if I can show you a picture of that one here. Here's this yellow median nerve. So you can see that one there. It is also running through the carpal tunnel. So when your tendons swell, they start to push on that nerve. And anytime there's pressure on a nerve, you're going to have pain. So the people that have, we call this carpal tunnel syndrome, people that have it typically have like numbness and tingling in their fingers. Sometimes it's pain, sharp shooting pain in their fingers. And so this is typically treated one of two ways. The more conservative way is to wear a brace. It's a brace that's going to hold your wrist so that you can't do this movement and overuse those tendons. Okay, so that's the first thing they'll try. If that does not help, then they will do carpal tunnel surgery. And in the surgery, they will go in and cut through that flexor retinaculum. So you can see that image on the right. They have cut through that flexor retinaculum, and all they're doing is just alleviating the pressure. Okay, now this is going to make your wrist less stable if they cut through that, but it does alleviate the pain. Let me pull up. I might need a second. I'm going to see if I can pull up a video real quick of carpal tunnel surgery. I like the music in the background. So you're awake. They just give you a local anesthetic. So remember, antebrachium is your forearm, and fascia sits on top of the muscle. me pause so I can tell you what they're doing. So what they're doing right now is they've made just a little incision, and when he says freeing the median nerve, that's that nerve that runs up that supplies all these muscles in here. And so they're freeing the median nerve, meaning they don't want to cut that. If they cut that, you're not going to be able to contract some of these muscles up here. So they're freeing that nerve so they don't have any damage to that nerve. They're making sure it's out of the way. Just making a bigger opening so they can put the scope in. Okay, yeah, so see how that's real shiny, like the ligaments? Remember when we did the chicken dissection? So you see that blade was lifted up. You can see it now cut. Okay, so I'm gonna just stop it there. So basically what they do in this procedure, how they used to do this is they used to basically make a huge incision down your palm, all the way down the palm, and open it up and then cut from above. They'd cut through that flexor retinaculum. In this surgery, you could see they did it differently. They made a little tiny incision and they went under the flexor retinaculum and cut from underneath. The benefit of this is that there is no danger really of cutting through that median nerve. When you're going from the top down, there's a greater danger of cutting through that median nerve. And also you could think about it, if you have a huge like 4 or 5 inch incision in your palm, it's going to take a lot longer to heal. This incision is like a 1/2 inch incision. It's tiny. They usually don't even put stitches in. They just use like medical grade super glue to seal that. So the healing time from this procedure, from the endoscopic procedure, is actually a lot faster. Okay, so that's typically what they'll do. You know, if you want to watch the rest of the surgery, you can, but that's pretty much it. Okay, so you could see that they kind of went underneath and cut from the underside. So it's pretty cool to see that. Okay. Now, I also want to walk you through a hernia. I'm not going to show you a hernia surgery. Don't worry. Hernia surgeries, you can watch them on YouTube, but I like the carpal tunnel one because it's really easy to see ligaments. It kind of gets you thinking about that chicken quarter, what they look like. This one, if you watch a hernia surgery, if you decide you want to watch that, it's when you're watching it, you're like, what am I looking at? So it's really hard to tell. But feel free if you want to watch one, you can. So a hernia, what is it? A hernia is when the abdominal muscles tear, and then the contents of your abdominal pelvic cavity will start to squeeze out through that opening. Now, they're not coming out of your body because you still have skin, but it results in sort of a big bulge in that location. Usually this is caused by lifting or straining. If you lift or strain, a lot of times you can tear your abdominal muscles if they're under too much stress, and then that can lead to that hernia. A hernia requires surgery. So if you have a hernia, if you have a tear in your abdominal muscle and you have abdominal contents poking out, surgery is required for that. And the reason is because think of like, okay, you got a tear in your muscle. You've got like your intestines are starting to squeeze through that. If you don't have surgery, what's going to happen is that tear in your muscle is going to start to heal, but your abdominal contents are still squeezing out. And the muscle is going to keep trying to heal, but your abdominal contents are still stuck. We say when your abdominal contents are stuck, we call that incarceration, which is kind of funny, right? You're stuck in jail or stuck here, incarcerated. And as that abdominal muscle heals around it, it's going to start to cut off the blood supply to your intestines. And you can lead to an infection, you can develop gangrene. The surgery is pretty simple, although watching it, it's very complicated in terms of what you're looking at. Usually all they do is shove your abdominal contents back in and stitch the muscle back together. A lot of times if it's a large hernia, they may have to use a mesh to help reinforce the muscle in that location. So let me walk you through the types of hernias. I just went back a slide. Epigastric is one that's sort of up in that epigastric region. Remember our 9 regions. Umbilical hernias are in the umbilical region, usually right around the belly button. These are super common in infants. My son had one. He did not have to have surgery. It's common in infants. It's a weak point around that belly button, and it usually will heal. Now, I would notice when my son would cry, his little innie would become an outie, but I could push it back in. And if he laughed or cried, it'd poke back out. It's gone now today. An inguinal hernia, this is down in near the pelvic cavity, pubic region, and this is very common in men. Men have something called the inguinal canal. This is actually an opening in the abdominal muscle because if you think about male reproductive anatomy, the testes are outside the body. That's where the sperm are being created. There is a tube that's going to carry the sperm into the body, and how it's getting into the body is through this opening in the abdominal muscle called the inguinal canal. So you already have an opening, you already have a weak point in men, and so if you're going to have any more of a tear and you're going to allow the abdominal contents to squeeze out, it's very common that it happens in that inguinal area, and you end up with an inguinal hernia. And then there's also a femoral hernia, which is down lower. We also have shin splints. Shin splints are, I'm sure you've all experienced this at some point in time in your life. This is in the front of the lower leg, so it's below the knee, between the knee and the foot, right? It's in the very front of your leg down there in the shin. And it's usually caused by running on pavement or walking really fast. And what is causing this is the muscle in that location is very different. So that muscle right in the front, that muscle in your shin, is called the tibialis anterior. And this muscle is wrapped very tightly in fascia. It has this connective tissue covering that's super tight. And what happens when you overwork the muscle, and think about where the muscle is, it's the front of your leg. So its job is to lift your feet up. Okay, so walking fast, running. And so when you overwork that muscle, anytime you overwork a muscle, it's going to swell. Well, because the tibialis anterior is wrapped so tightly in fascia, it starts to swell, it has nowhere to go, and it starts to push on its own blood supply and its own nerve supply, and this becomes painful. So that's where the shin splint comes from. The best thing to do to stop a shin splint is to stop the activity. Let the muscle come back down in size. Okay. Stretch, that'll help as well. And then the last disorder I'll mention is a Charlie horse. This is a bruise to the muscle. It's usually the muscle tears, you get bleeding in the area. That's what a bruise is. Very common in the quadriceps and in the hamstrings. And it causes pretty severe cramping. Now, the cramping can be caused by hormonal imbalances. So women, a lot of times when you're going through menopause, you might get Charlie horses more often. Dehydration, some people, when they get dehydrated because the electrolyte balance in your tissues is off, you get Charlie horses. And then sometimes it's even a side effect of medications that you might be on. Okay. So those are super painful if you've ever had them. So that is it for chapter 10. We just kind of walked through how we name our muscles and just some specific muscles, but not all.